Hello and welcome again to Schein TV. I'm Peter Norton. Thanks for tuning in. In this episode we'll be taking a look at technologies for early caries detection, specifically the DIAGNOcam. In everyday practice as dentists we're called on to look at clinical presentations with a trained eye and provide diagnosis and treatment for our patients based on what we see. So it makes sense that any new technologies that can help us to see more have got to be good for helping us to offer our best care to our patients. Eleanor Roosevelt once said, "It's better to light a candle than to curse the darkness," and today we'll see if technology can help us do just that. In a short while, we'll have a patient sitting in the chair and we'll be showing you precisely what we can see with and without the DIAGNOcam. I'm joined for this episode by Professor Laurie Walsh, lecturer at UQ and dental technology geek. Prof Walsh, welcome to Schein TV.
Thank you, Peter. A pleasure to be here.
Now, you have a reputation for being a bit of a dental techno geek. Is that fair?
I think it's well and truly deserved, Peter. Absolutely.
Well, it's great to have you with us. Our event this evening is scheduled to run for approximately 1 hour. As always, we encourage you to interact with us by sending us your questions and comments. In order to do that, please take out your smartphone right now, open your browser and go to the website shown on your screen. It's schein.tv. Once you've done that, click connect and you can send us as many questions as you like. We'll get to as many questions as time allows. By joining us here this evening, you're eligible to claim 1 hour of scientific CPD. At the end of the event, we'll give you instructions on how to register for your CPD certificate. But before we get started, let me tell you a bit about our guest this evening. Laurie Walsh has been Professor of Dental Science at the University of Queensland for the past 15 years, where he leads the research program in advanced materials and technologies. Laurie is a registered specialist in special needs dentistry and has particular clinical interest in how advanced technologies can improve patient care. He's published extensively on optical-based diagnostic methods used in dentistry and on applications of lasers in dentistry for diagnosis as well as for patient treatment. Laurie, why don't you start by talking to us a bit about early caries detection, the history of early caries detection and where DIAGNOcam fits into that picture?
Thanks, Peter. I think DIAGNOcam is a nice example of the evolution of a series of ideas around visual diagnosis of dental caries. So if we go back to the time of Pierre Fauchard realised that having a patient in a dental chair and using an operating light could improve the recognition of cavities. And at the time he also recognised there were early forms of caries, which today of course we call white spot lesions. It was around about 30 years ago that the fluorescence properties of tooth structure became really important, and that led to inventions such as laser-based fluorescence systems. A good example would be something like the DIAGNOdent. Then we had fluorescence-based systems to show us the caries inside a tooth. But along the whole process of the journey, we've also been using the way that light scatters around inside a tooth. I know when I was a dental student in the late 1970s and early 80s that we used fibre optic transillumination. We used to have small little lamps that we would place in between anterior teeth to look for interdental caries. That's exactly the same sort of process as we're using with DIAGNOcam, but the difference is instead of using a little yellow light bulb or a white LED, now we're using a laser. And that means instead of having a broad wavelength of light, we've now got quite a narrow wavelength of light. So the whole dynamics of how it scatters around inside a tooth are actually made a lot simpler. And what essentially happens in the DIAGNOcam is that the laser light, which is near infrared, penetrates through the tooth structure. And when it hits various boundaries, it reflects and comes back. When we have areas that are rich in water, we get a lot of forward scatter of light, which means it doesn't come back into the camera. And so the area looks dark. And this gives us a really interesting effect, which essentially is that the areas which we should be concerned about look dark in the same way as our brains are trained to look at a radiograph. When we see darkness on a radiograph, we interpret that as mineral loss. Well, in a reflected light image for fibre optic transillumination, it's a very similar process. This area looks dark, so we're suspicious about it being caries. Another important difference is that the technology for looking for fibre optic transillumination improved about 20 years ago with the very first system designed to use digital enhancement of that image. And unfortunately, that system wasn't really widely used and it had disposable tips, which meant it was actually quite expensive to use it each time. Whereas now we have a system that has tips that can be used for over 100 different sterilizer cycles, and that makes it a lot more economical and simple to use with a patient. And of course, now today it's linked to a digital world, so it's now linked to a patient database.
So when you talk about areas that are rich in water, that would include a carious cavity or?
Yeah, not just a carious cavity, but let's say a patient had developmental defects of the enamel. They had enamel that was hypoplastic. You would see on a tooth, you'd see an area that may be discoloured, you'd see a white spot lesion. Using DIAGNOcam, we can look into the tooth and get a picture of, in 3 dimensions, what that is starting to look like. And very similarly, when we have a place where the tooth structure changes direction suddenly, the light hits a boundary. And that's what happens when we have a crack in a tooth. And that's why we can use a DIAGNOcam to look for cracks as well as for areas of enamel that are water rich. So it's not just a device to look at caries. That would be a simplification in the same sort of way as a DIAGNOdent doesn't just look for caries, it looks for the presence of bacteria using a different process. They're both lasers, but one is using fluorescence light produced by, in this case, bacteria. That's DIAGNOdent. The DIAGNOcam is using light that's being shone through the tooth and back up into a camera. So it's probably easy to think about it like a really sophisticated intraoral camera that gives us a 3D view of the world that we're working in.
But in contrast with a standard intraoral camera, it's not just, the wavelength is much more telling than so essentially
right.
What is it that we're seeing through the DIAGNOcam that we wouldn't see with an intraoral camera?
Yeah, so with an intraoral camera, we get relatively limited penetration of light into coronal tooth structure. When the concept of diphoto was first really developed about 20 years ago, they used visible red light, which penetrates better. The DIAGNOcam uses just over 780 nanometers, which is in a part of the tooth called the therapeutic window, because that light penetrates through enamel and dentine extremely well. And that means that the light goes deeper into the tooth structure. And that's why in a DIAGNOcam we can actually see the dentine core of a tooth surrounded by this translucent rim of enamel, much like the tooth being sort of dissolved away, and we can see this core surrounded by an external part. And as we use it at DIAGNOcam, those sorts of mental pictures, you can actually get those from the images that we'll be producing.
And when you say diphoto, that refers to the wavelength itself, isn't it?
The diphoto means it's digital imaging fibre optic transillumination. Whereas if I pick up a little wee torch and put it between my front teeth, that's just transillumination. If I use a fibre optic, that's fibre optic transillumination. If I use digital imaging, so I'm using a little CCD or CMOS camera to collect the light, that then makes it diphoto. So they're, if you like, they're just progressions along a series of thoughts.
Nice.
Yep, good. So it's a technology which I think today adds something considerably to a problem that I've certainly run into in practice, and I'm sure you have as well. It's trying to get patients to understand there are lesions at a stage before they're a cavity. Because a lot of my patients think about tooth decay as a cavity. They don't really realise it's been going on for quite a long time before they get to that period. So when I'm looking at a patient who's got a white spot lesion, particularly interdentally, I need to somehow make that real to them if we're going to have a discussion about trying to arrest or reverse that lesion. And when I'm trying to monitor that, at the moment, of course, I've just been using sequential bite wing radiographs. But of course, with the principles of as low as reasonably achievable, how do we achieve radiation hygiene and still keep a good eye on an interdental lesion? It's a really tricky balance to make right.
I have the DIAGNOcam myself, and I really love it for the fact that I can use it on patients who either don't like X-ray films, despite everything I've told them about its relative safety, but also I can guilt-free in the way this practice runs, cost-free to the patient, still monitor things really closely in between X-ray films.
And I think an advantage is that when we see images with the DIAGNOcam, we get a perception of where the lesion sits in the 3D structure of a tooth. When we look at a bite wing, we're relying on mineral loss as we compact a 3D structure into a 2D image. So typically, we need to have lost 1/3 of the buccolingual width of the volume of mineral before we can see a dark spot on a radiograph. Whereas with DIAGNOcam, we can look down into a tooth and see something which is down to a 10th or even a 20th of the total mineral volume loss of the tooth. So we can see lesions that are earlier that we wouldn't ever see on a radiograph. So we're seeing disease our patients have got, we've just never been able to see it before.
And when we see that disease, I mean, and if we're able to implement a stringent remineralisation regime and the patient is a good soldier, would we ever see what looks like a diseased bit of tooth structure return to normal appearance on a DIAGNOcam image?
Absolutely. I think it's one of the most interesting uses of it. It's not just to show where disease is present, but when we're applying a therapy, so we're placing something interdentally, we may be, for example, using a CPP, ACP, having the patient brush and clean, change their diet. We should actually be seeing mineral fill the area in, and as it does, all those little crystallites act as little light guides to change the movement of light through the tooth. It becomes isotropic once again, which means the light moves through it in much more of a straight line. So we would actually see those areas fill in the same way as on a radiograph we would see an improvement in mineral. On a DIAGNOcam image, we would see the normal enamel translucency return, and that's something we can show to a patient.
So would you ever say that a DIAGNOcam image would replace an X-ray image in terms of, you know, caries detection?
Well, certainly there is evidence actually comparing exactly those two things, and a lot of that research has then actually opened up the teeth of course in real patients and actually tried to see what is the reliability difference between taking a radiograph or using a DIAGNOcam. And in fact, the performance of those two things is equally good. But we need radiographs to look into the structure of metallic parts of teeth. We need them to look at root apices. We need them for a lot of reasons. So it doesn't mean you can, retire the X-ray away. It just means that there's now something we can use to gain information that doesn't involve irradiating the patient if we're just looking at, for example, interdental carious lesions. But the science around diphoto, which is now over 20 years old, does consistently show that this equality to bite-wing radiographs for interdental lesions is certainly there. And that's been shown with the DIAGNOcam, certainly in the most recent studies that have come out in the last couple of years.
Great. Our first question, what are the limitations of DIAGNOcam?
Well, because it's an optical method, we need to think about the way that light moves around inside teeth. So if we have a tooth that's got, for example, a full gold crown, a tooth that's covered by stainless steel crown, then clearly we're not going to be able to get the light in and get the light back into the camera. So anything which is opaque to near infrared light, so that's going to mean a full metallic restoration, is going to be something that we simply can't get the light into. So it's basically a no-go zone. And because of the way that the light is brought into the tooth and collected in a camera which sits on top, we can't see subgingivally. So we don't really have a technique or device to take this idea subgingivally. So that would be the other major limitation. The third one, which really relates to the first point, is that if we have really intense deposits of stain on the tooth, that's going to absorb some of the light coming in, and that's going to mean that the image is going to be essentially covered over, a bit like partially masked out. So as long as we understand it's basically about the way that light moves around, the other things actually make sense about where it would not be all that useful.
In my own experience, I've found that it can be of limited use on anterior teeth. Can you tell me why that is?
Yeah, part of the reason for that is that anterior teeth, of course, get quite thin, and as they come up towards the incisor ledges, there is a type of an effect which is often referred to as pipelining, which means that the intensity of light gets very strong. So you would have noticed on the images, you get these sort of great white areas where it almost sort of burns out in terms of high exposure. And I guess to be entirely fair, the way that the tips that we have with it are designed was really to maximise looking at premolar teeth and molar teeth, because with incisor teeth, it's actually very easy for us to see where we're going, and also to directly transilluminate those using conventional LED transilluminated probes. It's really the posterior teeth where we can't use our eyes to see around the corner because we've got the structure of the cheeks and everything else in place. So that's partly to do with the anatomy, but more because of just the way that the actual tips are designed to work.
Understood.
Yep.
If you've just joined us and you want to submit a question, please take out your smartphone, go to the browser, open your browser on your smartphone and go to the website shown on your screen. It's schein.tv, click connect and you can send us your questions.
One of the interesting things that I've found with using DIAGNOcam is to uncover lesions in patients who had absolutely no idea that these lesions were present. And I've sort of found it works almost like a type of co-discovery. Because these images show teeth being naturally quite translucent, when patients see areas that are dark, they almost intuitively know that this doesn't look right. I mean, is that what you found?
It's certainly what I found. I think as well, as dentists, we're so used to looking at X-ray films and they make perfect sense to us, that we forget what it was like for us on our first day of dental school when we looked at our first X-ray film and said, crikey, I don't see what's going on here. Because we're just so used to it, we forget that patients are not on that journey with us. I find because the DIAGNOcam images are much more photo-like, that they're much more relatable. It also helps that the problem areas show up as darkness, as you said.
Yeah.
So we've had a question here about under which situations could we expect false positive results, and I guess that sort of relates to what you've already talked about.
Yeah, probably the main area I see false positive results as a problem is when patients have a lot of dietary stain in the fissure system, and a lot of our patients do have lots of highly coloured foods. And if we go through with a particle jet cleaner, we can easily clean all that material out. And of course, if we're using another fissure caries diagnostic tool, such as a DIAGNOdent, that stain is also going to cause a false positive for that too. So we've got a few reasons that we want to clean the fissure up, just so we can have a really good look at it, essentially. So removing a bit of dietary stain is a really good thing to do. Otherwise, you might look at a fissure and just mistakenly read the fissure pattern as caries, instead of realising that the fissure caries would need to have spread underneath and given you a broader type of elliptical dark shadow underneath, which looks rather different.
Okay. Another question we have is, are we able to connect the DIAGNOcam right to the chair?
Yeah, that's a really good question. I mean, it's a relatively simple USB device that plugs in, and because it's essentially at the end of the day a digital camera, it can export images out in a generic format such as Twain. So a lot of practice software is set up that you can import a Twain image, and that's how a lot of radiography servers, PAC servers work. They move Twain images around. So you can bring that image in. But there's also a database that comes with the system that you've used, which then links images to individual teeth. And the reason why that exists is so that you can actually track a tooth over time and say, let's look at this lower four, this distal surface we were concerned about. What did that look like 3 months ago or 6 months ago? And it's just a nice way of organising a lot of images. Otherwise, when you're going around going click, 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 and I know it's very easy to get very trigger happy, then where does that image go? Which tooth did it come from?
Yes.
Yeah, and at what time and everything else. So the database is just a nice way of systematising that. But the actual images are easily exported out, and then you can email them, store them, back them up. It's just simply a TIFF format.
Now, I think we're going to be having a look at some DIAGNOcam images later, but essentially at what stage would you be, if you saw a shadow on a proximal surface of a tooth, at what stage would you say, look, it's time to put a high speed on that?
Well, see, that's the interesting thing, because we know that the correlation between radiographic images, to typical bite ring radiographs, and the presence of a cavity is imperfect. And we know that once lesions go about halfway into the dentine, that the probability of the enamel surface being cavitated is over 90%. But if we take, for example, the presence of the small nick on a bite wing X-ray, for example, or one that's just reached the DEJ, we know that it's a minority of surfaces that have actually broken down. So one of the things that we do with the DIAGNOcam is when we find areas that are dark, then we use additional methods to test the tooth surface to see if it's actually broken down. A lot of people put a piece of floss, pull that around, see if the floss shreds, apply a bit of cold compressed air to see if they can evoke a bit of dentine response. They're easy things to do, they're quite quick. Other people put in small separators, squirt a bit of light body and impression material in. So we can use these other guides. When people have become familiar with looking at DIAGNOcam images, their ability to be able to tell cavitation rises, because the way that light scatters around a cavity is even different again than light scattering around a white spot lesion. The amount of darkness and the boundary of that actually becomes even more distinct. And you've probably noticed this yourself, that the early white spot lesions on a proximal surfaces have relatively fuzzy boundaries, but when you've actually got a cavity, the boundary actually looks quite sharp.
Distinct, yes.
And that's because you've got a physical place where the light is now hitting and then changing direction. Exactly the same as with a fracture. The same little piece of light changing direction makes it look dark. So when people have got used to reading that, which doesn't take that long, their ability to actually identify cavities accurately goes up. And a recent study in Germany found that reliability was over 95%.
Nice.
To pick it. And it's something that you get with experience, of course, like everything else.
I mean, going back to what you're saying about a fracture, I found it's particularly useful for showing patients cracks in teeth. And for the same reason, I suppose, partly because it's a photo that they can relate to, and it shows up really well on a DIAGNOcam image, probably better than a standard intraoral camera in my hands.
Yeah, I would agree. And we still have patients who've got amalgam restorations, and around them, because we often get a little bit of silver or mercury sulfide stain, there's always a little bit of a grey appearance around the margins of an amalgam. And the thought always goes through our head, is there something happening at that margin or not? And with the DIAGNOcam, we can actually see these lesions around the margins of amalgams really very, very well, which then allows us to think about doing selective repair of individual margins and stuff like that. So I found one place where it helped to recalibrate my thinking was around the margins of amalgams was really very, very useful as an additional aid to other things that I was doing.
Excellent. We have a question about the cost of the system. I'm assuming that that's probably going to be something that viewers could talk to their Henry Schein rep about, because is that a fair comment?
Yeah, absolutely. I think when you think about the cost of a system like this, you've got the initial get the system cost, and then because there's some obviously pretty sophisticated fibre optics inside the disposable or long-term use tips, they have a limited number of sterilising cycles. So there is, if you like, a long-term consumable cost of the need to eventually replace the little handpieces that fit over the top, because they obviously get sterilised between individual patients. So,
and how many cycles would we expect from one tip?
150 steriliser cycles would be the typical specification for that.
Yep. And then after that, we'd expect some image deterioration, or?
Yeah, what will happen is that the fibre optic bundles inside, the adhesive around that will start to break down. So the images will get progressively darker. Right. And that will be a little bit of a clue. So often when you're just putting the tip on, if you just wave your finger over the end, that will reflect a lot of infrared light. If you're not getting a really strong signal back into the camera, that means you've got some degradation in your fibre optics. But if you can keep track of the approximate number of uses, I think as soon as you start to see it go dark, that's going to compromise your ability to get the best out of it. So it's time to wave the tip goodbye.
Good to know.
Yeah.
In terms of the software that comes with DIAGNOcam, is that a software that needs regular updating or any other maintenance that you're aware of?
No, not particularly. It runs in either 32-bit or 64-bit PC platforms, runs on several different versions of Windows and things like that. No, I haven't found it's needed a lot of updating. It seems pretty straightforward to use. I mean, people do use the DIAGNOcam without the tooth matching software, because it takes, as you would have found, a little while to go through and actually selectively photograph each tooth as you're working your way around. Other people like to use like intraoral camera and just have a good general look around, and particularly when they're seeing a new patient, to chart up their tooth-coloured restorations. Because of course most patients we see now have quite a few tooth-coloured restorations, and spotting them can actually be really tricky. If they're really well done, nicely tinted, if they're ceramic inlays and onlays. Whereas with the DIAGNOcam, there is such a difference at the boundary because of the cement and the margins that actually picks them up really well. And I found that was really quite a remarkable application that initially I hadn't really thought too much about.
No, look, I agree in my experience. We've had a question about item numbers. Is there an item number that can be claimed as regarding a DIAGNOcam image? Yeah,
it would be the intraoral photography, which would be the 071 code that we currently have in the ADA schedule. Would be the right code to bill for that.
All right,
absolutely.
Good to know.
Okay, I think we should put someone in the chair so we can have a look.
Welcome, Emma.
Lovely, Emma. Thank you.
Yeah. Emma's kindly volunteered to be our demonstration patient.
And Emma's just a really good example of a patient we see in practice, on first examination, the two teeth look just completely normal, and there isn't much to see, but you know, there's always some restorations lurking underneath, and this is just a great way of being able to spot a couple of those.
Excellent. So how would you like me to do? Should I just wander around the mouth?
Yeah, let's just wander around the mouth and let's just have a talk about some of the images as they pop up.
Going to be some pressure on your gums, or be as kind as I can.
So when you are using DIAGNOcam, these two little soft rubber edges move around the side of the gingiva. If you've got material in the fissures, such as fissure sealants almost always show up really, really well. You can see some bubbles of saliva. Here you can see really nicely the sort of the central core of the tooth, which always looks dark, and we can see this beautiful rim of enamel, almost as if we've sort of taken a cross-section through the tooth here.
Something I love showing to patients because helps them to see what's going on.
Yeah. Here we are looking around the molars. Now we can see there we've got some fun. We've got some fissures there. You can see that lovely rim of enamel around the outside. One of the things in using the DIAGNOcam is that we have to be happy to actually change the angle a little bit. Often when we use an intraoral camera, we really focus on just keeping the thing absolutely still, whereas here you actually need to wiggle it. Yeah.
I find that if I see a suspicious spot on a proximal surface, especially, that rocking the DIAGNOcam seems to help me see if the shadow will shift.
Yeah.
So if that composite were leaking, for example, would we expect to see some darkness at the margins? Or?
You would. There's actually one spot there is a little bit of darkness on the margin there. Yeah, it's just a really nice way of spotting, you know, really well done composites.
Yes.
And you can also see around the margins quite clearly in this view. There's an interesting discussion point about why some composites look different, and that's obviously because of the way the light is scattering around. So whether they're nanofilled, microfilled, hybrids. And in fact, even how well polymerized they are can actually affect that as well.
Interesting.
That obviously affects some of the way that the microparticles are distributed. Then as you're going towards the front there, you can see that sort of burnout effect from that sort of...
an example of a
pipelining effect.
Fall through, and across the sizes.
So now once we get around here...
So I'm on to 4.8 now.
Yep.
Sorry, I'm just...
Now this is a beautiful example of, you can just see the existing resin there in the tooth very, very clearly, looking around that. Some funky little fissures happening there. So while it's a little bit awkward, it's not actually painful for the patient to feel these little tips running around the side.
No, I find patients tend to respond to it quite okay as long as you let them know there's going to be some pressure. And certainly I find that practicing on myself initially was probably the best way to, you know, find out how it's going to feel, but also work out the amount of pressure that I could use without eliciting any great discomfort.
Yeah, I think that's one of the things that new users find is that they initially don't push it down far enough onto the occlusal surface, and they need to be comfortable that it's not actually going to hurt the patient. And it's actually designed to have like a natural stop that sort of brings it into position. And if you don't get it down far enough, then the image won't actually come into really sharp focus. So you'll soon find out if you just simply aren't getting it down far enough for those two little wings to engage the actual tooth.
And there are two sizes of tips, aren't there? There's a large and a small.
That's right. The large one's designed essentially to do your molars, and the small one's designed to do your premolars. And if you're looking at the sides of canines as well. So normally we just switch between those two tips. Although just on Emma we've just used the larger of the two tips.
Okay. Yeah. And for use in paediatric dentistry, would you tend to favour the small?
Normally the small tip will get you around most teeth. It's really when you run into a lower second molar that you might have wished that you'd actually put the larger tip on. But certainly the small tip will easily fit around a lower or an upper first molar because they're obviously quite long, thin teeth. And the light transmission through deciduous teeth is actually a little bit different, and I'm not sure whether you've noticed this, because the enamel is more aprismatic and less well mineralized. It's also a lot thinner. So you notice that when you look at these teeth, how thin and delicate they are compared to permanent teeth. But it certainly can be used in deciduous teeth really well, and I often find that adults may not really worry so much about radiographs, but often it's parents of children who are just
a lot about the kids.
Yeah, yes. Well, you know, a growing person, and
yes.
some research which was done by our Centre for Paediatric Dentistry found that if people weren't taking bite wings of children, they're actually missing a very large portion of the caries. Bruce Newman led a study which did exactly that. And of course, there's this natural reticence amongst people to take radiographs in children because they don't like doing it and they find it difficult to talk to the parents about it. So a device which can not replace radiographs but can get you that information that you need, I think is really useful in paediatric dentistry.
I found it great. Do we need to use a barrier on the DIAGNocam? If so, does that distort the image?
No, that's a really good question. So one of the things that happens when a device like this comes into Australia and goes through the process of the TGA to get approved is there's something called the essential principles. And what that means is that the manufacturer has to have worked out all the issues around infection control, reuse and sterilisation. So in the case of this device, we have essentially a large removable sheath which comes off, and that's designed to go through the steriliser. So any saliva on that is going to be removed by the cleaning process and by subsequent sterilisation. It's only an issue, as you found, when a big blob of saliva gets on the camera part itself, which just needs to be wiped off. So you don't actually need to put a barrier on, and that makes it different from the sort of little sheaths you have to put over an intraoral camera. We have to sheathe them up, and that does...
Hope it's on the right way. Yes.
Yeah, that's right. Oh, you get the image buggered up. Whereas with this, it's actually designed to work that way.
Yes.
Which is fine. So the images, they're really nice and clear. It's great.
Another question about another question about patients with gag reflexes. Do you have any tips on getting good images in those sorts of patients?
Yeah, I haven't found that patients gag a lot with this. I know the sort of patients that would gag having a bite wing because it gets down on that lingual surface, but this barely extends past the gingiva. So I found actually it's a lot more comfortable for patients to have, and I've never run into someone gagging with it.
I haven't either, but yeah, that was an interesting question. Another one, do you use a DIAGNocam every checkup?
I mean, you can. I think it's a very easy thing to do. You need to allow some time for it in the way that you've scheduled your checkup. So if your standard examination visit is this long, you need to factor in, if you're going to assign images per tooth, that's going to take you time to literally click your way around the different teeth in the mouth. So you might want to, rebuild the length of your appointment before you just simply throw it in to your standard appointment time and then find that you're running late all the time. So I think you need to adjust the appointment until you've got really familiar with doing it.
I think at least initially, yes. I find that I don't really need any extra time now that I'm quite comfortable with it.
That's right.
And now that my staff are comfortable with it as well. On that front, we've had a question about how not to accidentally activate the capture ring.
Okay, well I think that's something that I've been guilty of, and I know initially I'd rather take an image rather than not. So yes. I have been notorious for bumping the little switch, and I guess to be fair to the engineers who designed the tip, they did actually build it so you could touch that little ring in 6 different places and it would still work, which means if you do bump it, it will certainly take an image for you. But it's easy later to go through and just delete the extra images that you didn't want. It's not really a big drama, but you'll find initially you will tend to be a little bit gun happy, and I don't think that's a problem really.
No, look, and I think there are also incarnations of compatible software that allow you to deactivate the ring switch, but I think that's probably something to talk to the Henry Schein rep about.
Yeah, I would have said so.
In that sense, the technology that I work with, I say to my dental assistant who's standing next to the computer, click, and that's when he or she can capture the image for me.
Yeah, I would probably bet that in the future there may well be something like a wireless foot control, because using foot control all the time, it's easy for us to go click 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 with the foot. So that might be something that, rather than squeezing a switch and trying to hold the handpiece at the same time, people may find a little bit more convenient, and wouldn't be difficult to do.
We have a question here about why do we not see a change in colour in a DIAGNocam image when the light hits the pulp?
That's a good question. So the images that we're seeing are essentially monochrome images. So they're 256 grey level 8-bit images because the light is only one wavelength and the camera is just picking up that one wavelength. So the images are actually free of any tones. Now in the software, you can assign colour to the image, but it's pseudo-colour. So it's essentially a lookup table that says for grayscale value 123, it's this colour red. For 124, it's this colour orange, and so on. So that's completely false colour or pseudo-colour, and it's sort of meaningless. But the light, when it's coming through, the boundary of the DEJ is nowhere near as strong as as a boundary for the light to move through as the boundary between the odontoblasts at the very outside the pulp and the inner dentine. So that's why the biggest boundary that occurs as the light comes into the tooth is it's running into the DEJ. So there is light that does actually reach the pulp. The level of that is very, very low, and the signal it's partially distorted as that light gets reflected back through the dentine because it actually curves in line with the S-shaped bend of the tubule. So that amount of information is so small that we can practically ignore it. So we're really seeing most of the time what's happening around the DEJ or around the surface of restoration. It's the first dominant boundary is what you tend to mostly see.
So, as well as being a techno geek, you're also a well-renowned infection control guru. So, you've said that we don't need a barrier over the tip of the DIAGNOcam because that goes through the autoclave.
That's right. Yep.
How would you recommend sanitizing the rest of the handpiece?
Okay, so the rest of the handpiece when that slides off, which you've been holding in your gloved hand, actually wouldn't normally get saliva on it anyway, but it's actually been designed to be compatible with almost all the current surface products that are used for wiping down. So the sort of impregnated wipes, those sort of things, it's actually got quite a nicely built surface that's quite impervious to those things. So you can actually wipe down the rest of it. The part that you actually hold in your gloved hand that goes in the mouth, that's the bit that gets sterilised. So it's essentially like the tubing then of a handpiece that probably doesn't even touch a patient's body or skin because it's actually draped outside them. So that's
close by.
Yeah, it's the semi-critical bit that actually goes in the mouth is the bit that actually gets sterilised.
For a new user of the DIAGNOcam, how long would you suggest extending an exam appointment to incorporate DIAGNOcam into the treatment?
I would have thought you'd go for no more than 5 to 10 minutes initially. And I think the best thing to do with this, and this is probably typical for many bits of technology, is it's good to experience it on yourself, and it's great to do it to your staff, because then you get a really good feel and you're not feeling that you're worried about upsetting the person or running late. You just need a bit of time out of normal practice hours to just have a play and get really familiar with activating it so you're not worried about which switch is which and what's what. And I learned up by running it over my own teeth and just getting used to what the feel of that was like, so I could tell the patients, look, you're going to feel these little rubbery things like little legs on the side of your teeth. If it's a kid, I say, well, this might tickle a little bit, tell a bit of a story. And the time it takes to go around the mouth, then you sort of dry run that on your staff a couple of times before you then let loose on a patient. So by that stage, you're pretty comfortable with how it all works.
We have another question about for practices that have more than one chair, can the one DIAGNOcam unit be used in multiple rooms?
Yes, so there the limiting factor is to make sure you've got enough supply of those of the handpiece tips that go over the end. Yeah, so you just make sure that you've got
autoclavable component.
You just have a couple of those, and they're actually viable as a separate component. But it simply just unplugs from USB and just moves around. Yeah, so it's actually easy to do that.
From what I can gather, there has been some research regarding sort of DIAGNOcam and whatnot. I mean, obviously there's probably a whole body of it. What's the current situation in terms of the academic opinion?
Yeah, so there's been over 20 years of research on dye photos. It's been through different sort of systems. So what that research has typically done is to compare the way that dentists would read the same patient from their radiographs versus from their dye photo images. So it's an apples versus apples scenario. So there have been 2 recent studies of that type done in Germany. So what was done in the study in Germany was really interesting. They had a series of 85 consecutive patients who were suspected of having cavities. And when they looked at the performance for these interproximal cavities that weren't easily visible, and they then looked at, say, here's the digital radiographic image and here's the DIAGNOcam images, the actual performance was slightly better than the radiographs for the DIAGNOcam. The difference wasn't statistically significant in this study, but the accuracy was actually 99.2%, which is actually really very, very impressive, because as dentists, we tend to have good specificity. We know when something is healthy, but our sensitivity of finding disease and cavities generally isn't that good. So that was actually a really impressive result. In the study, using digital radiography, some of the best current systems, it was 96.1, just slightly lower. So the conclusion from this pair of studies in Germany was that they felt that for the diagnosis of caries on aproximal surfaces, the DIAGNOcam could be a successful replacement for bite ring radiographs. And that was that whole discussion around patients who were worried about radiation hygiene, child patients, those sorts of groups. And I'm sure you have them in your practice as well. The patients who are a bit on the fringe, who just, they don't believe in fluoride, they don't believe in Xrays, they, you know what they're like.
Why are you even here? Yes.
That's right, exactly. So there's now been two studies. One has only just come out in the last couple of weeks, and one was published late last year, that really give us this nice little body of evidence around the performance of DIAGNOcam in this sort of situation, because their gold standard was actually drilling into the teeth. And this was great, because then they could say, radio, there is a lesion here and this is how big it is. So that allowed them to get that feeling for how well the dentists were actually calling it versus what they were seeing on the image. So I think there's some really nice supportive data from these sorts of studies that give us confidence. And we know from clinical experience, when you make a call and you drill into a tooth, you soon learn that you got it right or you didn't, or this thing was bigger than you thought or not as big. And I know, when I was, early in my career, the number of surprises I got when you'd open something up and you thought it was small in the radiograph, but this thing was a lot bigger, and you go, man, this thing is huge. And of course, it takes a while to calibrate your brain around that aspect. Whereas with the DIAGNOcam, because it's showing you more the true periphery, you don't get that sort of surprise. It's like, well, I thought this thing was about that size, and it tends to be about right in terms of a volume perspective. So I think that's actually really useful.
Yeah, I've found it really good for my patients. We have a question about if there's a crack in a tooth, when would you start treatment or just monitor until there's symptoms in the tooth?
Okay, so I've found it's easy to sometimes get caught out when a crack is not a crack, when a crack is an enamel lamella. So in lots of older patients, you get these vertical lines, particularly in incisor teeth, which you can see, where you have an area where the enamel rods change direction. You get these little micro percolations over time that capture a little bit of stain, a little bit of fluid. So they're in us our whole life. They're just more obvious when we're older. We look at that and we go, you know what, that looks like a crack. But the patient's not getting a sign of pain on a release type thing. So it's not cracked tooth syndrome, it's just an area of an optical boundary in a tooth. And you can certainly see lamellae quite prominently when you're using the DIAGNOcam. But I think when you're looking for cracks in coronal tooth structure, particularly in posterior teeth, the place I see them all the time is around the edges of amalgams, particularly around marginal ridges and places like that, where you've just got an area of enamel. You can just see here's the crack running through that, and that helps me to bring it up and show the patient, say, see that? And they go, see that line? They go, yeah, I can see that. That's not good. We need to explore that further. And obviously we start to use a fract finder and see whether there's actually any symptoms of the crack opening and closing up. So we need to just be a little bit careful around anterior teeth, because you'll see lamellae, but they're not cracks. Whereas around restorations and in the posterior part of the mouth, you will see true cracks, and then we still need to use our other standard special tests to identify that we do have a percolating crack.
We have a question also essentially about return on investment. The question is, how long would what's the average time period before I can expect a return? What are your thoughts on that?
Yeah, I think one of the things that DIAGNOcam does is there is already disease in our patients that we simply can't see. So it's not about, I'm going to attract, 100 new patients a month if I get this thing because it's a bit of a high-tech gadget. I mean, that may or may not happen. But what about the patients we're already seeing who've got problems that we haven't identified, and particularly those who've got a lot of these early lesions that won't pick up on bite wing radiographs, and particularly in younger patients and especially in kiddies? I think there's this and we did a study of this in the eastern suburbs of Brisbane, where we found that the not seen disease was actually 3 times the bulk of what the actual identified cavities were in children. It was a study where we had about 3,000 services that we were tracking over several years in a large population of children. And it's, I think, fairly typical of the what's called the iceberg effect, that, you know, when you see a cavity, there's always lesions at earlier stages. And so in our own patients, there's already dentistry that needs doing, which we simply don't know about, and that's why we're not doing it.
Doing it because we can't see it.
And now that we can see it, it's like, well, here we go. And these are patients who we're already caring for, we've already got a relationship with. So I think that is the place where the return on investment actually comes from. It's actually doing a better job at caring for the people we're already looking after.
Yeah, I agree.
Yeah.
Can a dental assistant use the DIAGNOcam?
Yes, because they're not using it to make a diagnosis, which is a type of restricted dental act. They're just simply going like taking intraoral photographs. And in most practices, in mine included, DAs take wonderful intraoral photographs, and they'll, you know, set a patient up and present these records. And I know in a number of practices, part of their routine is to have the dental assistants go around with the DIAGNOcam and actually do that systematic imaging of each tooth. So there is already that database built up for when the dentist completes their examination, they've got access to all that information. So it's the same as taking an intraoral photograph, because that's what it is. An 071 is an 071 is an 071. Yeah.
We also have a question, how long do the bulbs last for?
Okay, so there's no bulb. So in an old style fibre transluminate, you used to have these little miniature Edison screw bulbs, which were a bit yellow and they used to die occasionally. Then a number of companies brought out white LEDs with transilluminated tips. So white LED has a mean time before failure of about 50,000 hours. That's about the same as a dyed laser. So having the unit on for 50,000 hours will see most of us very comfortably through a very large part of our career. So for all intents and purposes,
for as long as we want.
For as long as you want, yeah. It's because it's not a bulb, because it's a little tiny dyed laser, the same sort of dyed laser as we'd find in a laser pointer used in a lecture theatre, for example, or for example, the same sort of dyed laser we'd have in our CD player at home. It's just generic consumer electronics, and it goes for a very long time, which is great.
On the laser front, because it's a laser, do we need to use safety glasses?
Yeah, that's a great question. So the way the light is delivered is really very, very clever. So it's captured between those illuminators and the camera, and that's opaque. And because of that, and the fact that the actual emitted light is less than about a milliwatt, it's actually at a place that makes it completely eye safe. So the laser radiation doesn't get out of that little enclosed environment. It doesn't reach the eyes, and that's why the patient doesn't need special, laser eyeglasses to have DIAGNOcam using them, nor do we as the users need to have that on in order to use the device, because it's actually classified as a class 1 device. That means it's inherently eye safe. And that's great. That makes it really easy to use.
It does.
Yeah.
Another question about the length of the cable available. I mean, what kind of range are we expecting from computer to patient?
Well, the nice thing is because it's USB, it's easy to get a USB extender. So the question is, how long is a piece of string? But the answer is long enough.
Would we expect any image deterioration if the USB extender is particularly long?
I think if you went over 5 metres, you might start to expect a little bit, but I don't think anyone's probably going to be 5 metres from their computer. If you are, you're very lucky to be working in a very large operatory.
Sounds good to me. Another good question, when teeth overlap, well, in terms of their alignment, it can be really difficult to assess them on a bite wing.
Absolutely.
Is the DIAGNOcam of any help with that? Does it also struggle with overlapped teeth?
No, I mean, you've played with this long enough as well. You would have found this. It's just a question of just moving the angle around to get exactly the view that you want. I mean, because of the way that arches curve, even when we line up a patient for an ideal bite wing view, we often see a few areas of overlap, and we sort of, okay, that's just the way it is. Whereas with this, we can spend just a few moments just getting exactly the right position of the tip to make sure that we don't get anything other than exactly the view that we're looking for. So I haven't found that a challenge. What's been your experience?
Look, I think if teeth are really misaligned, so for example a lower premolar that's basically squeezed in or out of the arch, that's going to be tough to get anything around. So yeah, I'll tend to rely on a DIAGNOdent and conventional trans-elimination in those situations.
Yeah, because what we often forget is when a tooth is either pushed lingually or buccally in that situation, where the carious lesion is going to occur is going to be in a different place. So it's never going to be out, where it was originally going to be, out sitting under what was the original contact points. It's going to be tucked in where those contact zones are, where you've got that really, dense, mature plaque. So we still have to recalibrate where we're going to look anyway.
Now, do you feel that a DIAGNocam can take the place of an intraoral camera? There's a question here, can DIAGNocam be changed into an intraoral camera?
Well, it's if you like, a very specialised type of intraoral camera. There are times we use intraoral camera to show patients colour, and a really good example is I use intraoral cameras all the time to show patients gingivitis and periodontitis and things like that. So the use of colour is actually quite important to show that. So I don't think you can have a completely monochrome approach to life. I think it's really good to actually have some colour on an intraoral camera. So I think it's actually worth doing. Yeah.
So do you mind talking us through how you monitor interdental lesions in your own patients?
Yeah, so I think this is a place where the software comes in really good, because you can link an image on a particular date to a certain tooth and bring it back and look at the patient again in 3 or 6 months once you've done some changes to lifestyle, diet, oral hygiene, and you've been using a room minimizing protocol. You should see that area start to become more translucent, so it should be starting to scatter the light back at the DJ rather than the light being scattered forward and the area looking nice and dark. So I think that's a really good example of how you would do it, and it only needs to be a short visit to get the patient back for a recall. And I think the patients get encouraged by the fact that we're trying to be as conservative as we can for them. We're not racing into restore. We're saying, well, let's give this thing a chance to go. We're pretty sure the surface isn't broken. You haven't got symptoms yet. Let's try to gain you some arrested or reversed enamel caries back into sound enamel and stay with that. So that's just a much better way to go.
Look, I agree. I hope my patients appreciate the same thing. Another question, does the picture quality vary depending on whether we use the overhead light or not?
Yeah, I guess with most trans-illuminating methods, and DIAGNocam is really no different, the least stray light you have, the better. Now, it does make a difference whether your overhead light is a halogen light or whether it's an LED light. And the simple reason for that is if you have a halogen light, you have large amounts of yellow, but also have some of the longer wavelengths, such as the reds and the infrareds. So if you have an older halogen light, it's actually better if you actually turn that light off, because you are throwing some infrared light into the picture and it can get a little bit messy. So that's why I like having the operating light just simply turned away. That just cleans up the signal to noise ratio, to give it its technical term. And that's also true if you're using an LED tip, for example, to do transillumination of anterior teeth. You see a lot more when you've got the operating light turned away, because you've just got a darker background field. And so while the tip acts as a bit of a shroud to reduce the problem, I think if you've got a halogen light, I'd have the halogen light turned away. The LED lights don't throw out infrared light, because a white LED light, as we have in modern operating lights, is actually a blue LED with a phosphor. And those two things don't emit any infrared, so they don't really mess up the image to any great extent. So with a modern LED light, the answer would be it shouldn't make any difference. With an old halogen light, it could, so I'd be moving it away.
Okay.
Yep.
We also have a question about if we're telling our patients about these non-Xray or non-ionising radiations we have available, are we then essentially perpetuating an Xray phobia in our patients? How do you handle that?
Yeah, I mean, I always tell patients, there are things that we need to take X-rays for, and this is just an adjunct to that. But I always talk to them about the relativities of dose, and I do that in 2 ways. I talk about the relativity of X-ray exposure compared to normal background radiation. So you say, okay, this radiograph we're having today is the same as 1 day of background radiation, assuming you're on the ground. When was the last time you went for a flight? Well, when you're up in the air, you get more background radiation, etc. Or there was an interesting study which Paul Abbott published in the Australian Dental Journal about 10 years ago, which I still talk to my patients about today, which was the relative risk of an adverse outcome, and it compared to lots of probability. So you can give patients a relativity. For example, the chance of you getting a cancer and dying from this radiograph, that chance is lower than the risk that you took driving 200 metres down your street to come to this appointment today. So you can weigh things up using those sort of statistical risks. But I agree that some patients have an X-ray phobia, and it's best if we talk about background radiation so they understand there is background radiation, and what we do them is simply a multiplier of that. And I think most people can be brought around to a reasonable view. But I've got patients, I'm sure you do, who are just like completely anti all that stuff. So.
Yes, I relate. I tend to tell them that, like anything, this doesn't replace X-ray films. X-ray films don't replace this, but it does give us information that previously we just haven't had available to us.
Exactly.
What feedback have you had from patients about having the DIAGNocam used on them?
They said it didn't hurt. It was surprisingly comfortable. They felt it was really not much different from having an intraoral, lipstick type camera used on them. They found that they could actually understand what the images were about, because it wasn't just a flat surface, but it was actually a really nice three-dimensional view of the entire tooth. So I think they actually found it more interesting and engaging, would be probably how I'd describe it.
Yeah, look, I agree. Yep. I find patients often want to look at the screen that's in front of the chair while I'm taking the images, and I've got to say, look, I'm sorry, I'll show you the photos once we're done, but I need for you to have your head back so I can see what I'm doing.
Yeah, absolutely.
Look, we're almost out of time. Do you have any closing comments at this stage?
Yeah, probably. In my experience, while I was initially really interested in what was happening with carious lesions, probably the thing I didn't realise most at the time was how useful it was just for spotting where tooth colour restorations were in patients, just to get a bit of a feeling for what dentistry they'd actually had and how well the dentistry was actually going. Because I've always found it harder to spot caries around tooth colour restorations than around amalgams, for example, or around crowns. So that was just something which I just learnt in my own experience. So I'd encourage people who are using it to really try to get the best out of it and spend some time looking carefully at all the tooth colour restorations and sealants that you find, and don't just limit it to just looking at interdental lesions, because I think that would be a bit of a mistake.
Well, that's all we have time for today. Thanks again to Laurie for joining us for this evening, and of course to you, our audience, for joining us as well. If you haven't already done so, you can click on the button below the video to register for your CPD certificate. Dentists in New Zealand can register for their CPD certificate by emailing Henry Schein. Also, if you're looking for more information about DIAGNocam, check back at the Schein TV website over the coming days. I hope you've enjoyed the event. Thanks again, and see you soon on Schein TV.